Hi, very good morning from Manual Therapy Foundation of India, and I am glad that Physio Harcon is organizing so many days of conference, and I appreciate Dr. R.K. Mudgil and his team, and I also appreciate Dr. Manoj Deshmukh for his nice introduction. And I am live from Manual Therapy Foundation head office from Mangalore, administrative head office. And with me, Dr. Basu is there. He will be the model, and Dr. Ani, she will be helping me. So that this is about my presentation is regarding the manual therapy of the knee complex. And I believe that in different time zones, people will be watching across the world or maybe afterwards, because it is a recorded video. So my hearty greetings to all of you, and once again my hearty appreciation to the team of Physio Harcon for organizing this conference. Okay, so Dr. Ani, just help give me the right. So when we talk about the knee complex, very frequently as a physiotherapist will be encountering the problem of the knee joint. And the knee joint, you see, we have the tibiofemoral joint, and basic the concept of the convex concave rule is very much appropriate here. And you can see here the inferior part of the femur is convex and the tibial condyle is concave, and here we have the meniscus to distribute the load, and here the concave rule is applicable. What is the concave rule? If we remember, when a concave surface is moving with respect to the convex, we have the gliding happening in the same direction as the bony movement. And if somebody has got a restriction of flexion, because many times as far as the focus here, right, as far as the problems we will come across, that sometimes following the any fractures after the cast removal, we may have the stiffness, and that time we have to check for the end fills. What is the end fill? Common end fill we come across in the knee joint. One is towards the extension, we will have bony end fill, and towards flexion normally we are supposed to have the tissue approximation end fill. And in case of restriction, very often we will come across the capsular end fill or leathery end fill. Now, if we are getting a leathery end fill, there is a movement of there is a restriction of flexion, then we are supposed to give the anterior to posterior glide, epiglide. You can see here from the tibial tuberosity with the first waist space we are supposed to give, and of course while mobilizing the knee joint, we have to put the joint in the loose pack position. So what is the loose pack position of the knee joint? About 25 degrees of flexion, that is the loose pack position, and complete extension is the close pack position. So we are supposed to put it in the loose pack position, and then we are supposed to give the glide. That is the very fundamental principle of application of any mobilization technique. So I was talking that suppose we have got a restriction towards flexion, and we are going to give the epiglide, and suppose there is bony end fill, due to some reason there is bony end fill, then in those type of cases, of course it is quite difficult that even if we go for any kind of mobilizations, we are not, maybe it could be due to malunited fracture, or there could be some implant which is done, it may be interfering with the joint articulating or arthrokinematics. So that is something what we have to remember. If we have got soft tissue end fill, say especially the capsular end fill, then there is a possibility of getting the joint play and getting the range of motion and curing the some following the cast removal. If there is some stiffness, then it will be more useful. So I will show you now epiglide and then PA glide. Posterior to anterior glide is for extension. If there is some restriction towards extension, then we have to give posterior to anterior glide. Another important is another two glides are there. Along with the epiglide and PA glide, we have lateral glide and medial glide. We know that the locking and unlocking of the knee joint. The knee is getting locked in extended position and it is getting unlocked in flexion position. So when we are going for flexion, then there is internal rotation. That's how, and with internal rotation there will be a lateral glide. So again, for flexion we can give the epiglide and we can give the lateral glide, and for extension we have to give the PA glide. Primarily it is the PA glide which is going to be more useful, PA glide, and we can give the medial glide. So that is about the tibiofemoral joint. Then next coming to the patellofemoral joint. So patellofemoral joint, I'll first demonstrate on the model the various glides for the tibiofemoral joint. That is the epi glide, PA glide, medial glide, and the lateral glide. I'll show the belt mobilization also, along with how we can, along with the mobilization, I will show you the how to apply the belt mobilization also. And yes, now I will take the help of Dr. Basu. He will become the model, and please lie down. And we have to put the joint in the loose pack position. I will just focus, right, and yes, we are focused, well focused, okay. And so once again I will show on the skeleton. You see, we can give the anterior to posterior glide, epi glide, and then the PA glide. Then we have the medial glide and the lateral glide. So on the model we can put the pillow, and it's kept in flexed position, that is the loose pack position, and I am giving the anterior to posterior glide. So we can stabilize with our thigh also. We can keep the pillow, or we can put it this way, and I'll just focus it so that the visibility is more better and clear. From the tibial tuberosity we can give the anterior to posterior glide. So I'll just place it in a place the camera in little bit more visible area so that it is more clear. Yes. So now you can see tibial tuberosity is here. I have stabilized above the knee joint, distal posterior aspect of the thigh, and I am giving the anterior to posterior glide. So with the various grades, grade 1, 2, 3, 4. The basic fundamental is that whether you are applying any of the methods, but for flexion you are supposed to give the epi glide, and for extension you can give the PA glide. And whenever there is a lot of stiffness, we have to start with grade 3, and for pain management we have to apply with grade 1 and grade 2. So epi glide and PA glide. As I said, that epi glide is for flexion, PA glide is to increase the extension. And then we have the lateral glide. Stabilize the distal lateral aspect of the thigh, upper medial aspect of the tibia, and as I said that we have to put the knee in the loose pack position. That's about at least the 20 degrees of 20 to 30 degrees of flexion. So you give the lateral glide. This is the lateral glide again, that for flexion we have to give the lateral glide, and for extension side lying position, and for extension we can give the medial glide, right. And I'll show the mobilizations using the belt for okay. Now come to supine line. All right, you can take the belt and you can give, see here, you can give the posterior to anterior glide, you can give the lateral glide, you can give the medial glide, and you can also give the anterior to posterior glide. And come to prone lying position. So we can also give the mobilizations with the movement. You can go for the knee flexion, say you can give a lateral glide and maintain that glide, sustained glide, and then ask the person to take it for flexion, right. Similarly for extension, you can give a medial glide and then ask the person to do the extension, right. So we have these are the mobilization techniques, and similarly we can apply some thrust techniques, especially for intra-articular loose bodies, where we will have some springy block end fill. What is springy block end fill? While we are doing the movement passively, in case of internal derangement or intra-articular loose bodies, while you are performing the movement may stop and rebounds back. That is called a springy block end fill. So for that, what we can do, we have some, I'll show you one thrust technique where we go for the tuck pull grasp. The thumb is kept in the third way space. So we go for the tuck pull grasp. Why this grasp tuck pull? Why I am using the term tuck pull means, if you remember, sometimes in your school days, you would have, one side some 5-10 people are standing, other side 5-10 people are standing, and they are holding the rope and then they are pulling. That is the tug of war. So in the tug of war, you are supposed to ideally have this grasp. Next time you go for tug of war, you go for this grasp. And also for patient management, wherever we have to give traction and all for the limbs, we have to go for this grasp, because there will be minimal pull of the soft tissues and minimal pull of the hair. So we go for the slight traction. We can ask somebody to stabilize. Somebody can stabilize here actually. Then you can give the traction and you can go for thrust techniques, rotation thrusts. So this is for the treatment of come to supine line. This is the thrust technique, and definitely we have to be careful. Some of the extreme contraindications we have to remember. What are the extreme contraindications? Like fracture displacements, like infections, osteomyelitis, cancer. So these are the red flag conditions, and severe yellow flag, when there is a psychological impairment is there, yellow flag conditions. Especially fracture displacement, cancer, infections, these are the red flag conditions where we are not supposed to apply the thrust techniques. And somebody with old age and corticosteroids, in those cases also thrust technique we should not apply. We can go for gentle mobilization technique. That is absolutely fine. And another important technique I'll show you, that is especially for osteoarthritis. When somebody comes with osteoarthritis, obviously one of the prime complaint is the reduction of the space. So in that case, what you can do is you can put the lateral aspect of the forearm in the popliteal fossa posterior to the knee joint, and you just apply a force upwards. So it's like, you just imagine it's like reverse V. It's like reverse V. So we are giving a force from the posterior popliteal fossa anteriorly, so that there is distraction. If you imagine the V, reverse V, there are two components and it is going to get distracted. Very, very useful technique for the treatment of osteoarthritis of the knee joint, because one of the prime complaint is the reduction of the intra-articular space. So upper aspect of the forearm, lateral aspect of the forearm, we are putting posterior to the popliteal fossa, applying the force upwards, taking the knee towards flexion, and then you can give a small thrust. So this is something important technique for the tibiofemoral joint, and the next I'll discuss about the patellofemoral joint. So in the patellofemoral joint, so you can see here the I'll show you the mobilizations for the patellofemoral joint, right? So what are the various glides? I'll just show here. We have the caudal glide from the superior aspect of the patella. The caudate glide we have to apply with the heel of the palm, caudate glide. In case of patella alta, we have to apply the caudate glide. And next is the cephalic glide from the inferior pole of the patella. We go for the cephalic glide. In case of patella baja, it is written as BAJA, but it is pronounced as baja. It is not baja, as many of our, as Indian and Asian subcontinent, we are very fond of the baja. During marriage time and all, baja is there. So it is not baja. Don't be carried away with our Hindi baja. It is baha. BA is written as BAJA, but it is pronounced as baha. So we can go for the cephalic glide whenever there is a patella has gone down. And then we have the medial glide, and then the lateral glide. If we see the various patellofemoral conditions, one of the, say, patellofemoral arthritis or chondromalacia patella, one of the common condition of malalignment is lateral glide, lateral tilt, and lateral rotation. So in the corrective maneuver, we are supposed to apply medial glide, medial tilt, and medial rotation. Dysfunction, lateral glide, lateral tilt, and lateral rotation. So correction, medial glide, medial tilt, and medial rotation. So we have to give the mobilizations in that direction primarily, because lateral patellar tracking is common. If you see here, the medial condyle and the lateral condyle labels from here, if I show you, then there is a slanting angulation is there towards the lateral aspect. That's why there is a tendency for lateral patellar tracking. So I will be showing you the mobilizations, and then at the end I will show you the one important taping technique, that is the Macronyl taping technique, which is frequently used for the patellofemoral problems. So coming to the patellar glides, we have the caudate glide. The fast waist space is kept here, and we can give the caudate glide. So you can just I am relocating the camera, yes, so that the visibility is more better, yes. So coming to the fast waist space is here, inferior pole, heel of the palm. This is the caudate glide. In case of patella alta, high riding patella, you can go for the caudate glide. Then cephalic glide, the fast waist space are the superior aspect of the patella, heel of the palm, inferior pole, cephalic glide. Then we have the medial glide. From the lateral mid part of the patella, give the glide medial glide. Then lateral glide. From the medial mid part of the patella, give the glide lateral glide. And medial tilt and lateral tilt. Put one imaginary line at the mid part of the patella. So then it will be the medial tilt. The tilting is to the side where it becomes more close, medial tilt. Then lateral tilt. Medial rotation. Rotation is with respect to the inferior pole of the patella. Medial rotation, lateral rotation. Then we have the distraction, and then we have the compression. So these are the various gliding movements. Once again, if I show you, see this is the caudate glide, cephalic glide, medial glide, lateral glide, medial tilt, and the lateral tilt, medial rotation, and lateral rotation. And out of this, in case of dysfunction, we will have lateral glide, lateral tilt, and lateral rotation. So what is the corrective maneuver we are supposed to apply? We are supposed to give medial glide, medial tilt, and medial rotation. So I'll just show you the taping techniques for the patellofemoral joint. So we can use this is the pre-wrap, paper coated with silicone, and this is the rigid brown tape. You can use any of the tape, but preferably rigid tape will be more preferred than any, or elastic but relatively more rigid, that kind of tape. So you can take I'll give the various components. One is the, as I said, to the medial glide we give and tape. Then medial tilt, you can combine medial tilt and medial rotation, or you can give independent components also. This is the Macronyl taping you can give for chondromalacia patella, you can give for the patellofemoral arthritis, and we can just tear it up, but tearing over a period of time I develop some kind of fibrosis with my finger, and so you can we can tear it directly, but it will be better if you cut it with the scissor. So one is the medial glide, the next is the medial tilt and medial rotation. So we can give this component, the medial glide, the medial tilt, and medial rotation. So you can see the tape. This is the taping technique for the patellofemoral joint problem. And the last one, I'll just show you the technique for whenever there is knee involvement. Sometimes in the lateral and lower part of the knee we will have involvement of the tibiofibular joint. Pain will be, especially for athletes, runners, hurdlers, we can get this kind of problem. They are complaining the pain in the lateral aspect of the knee joint, but slightly below the knee joint if you palpate. So thereby we can give the various glides. We have got the AP glide, PA glide, and we can go for the manipulation. I'll just show you that technique. One, just focus here. Okay. So from the tibial tuberosity about 2 inches lateral, we can palpate for the fibular head, where you can give anterior to posterior glide, and when subject is coming to side lying position, we can give the posterior to anterior glide. Posterior aspect of the fibular head, you can give the posterior to anterior glide. Okay, come to supine lying position, and then the thrust technique. I'll show you the thrust technique for this side. So for the thrust technique, what we have to do, superior tibiofibular joint thrust, we keep the 4 fingers, these 4 fingers posterior to the popliteal fossa. The hip is flexed and it is adducted. Tibia is taken for external rotation. The knee is taken towards flexion. Just come this side, yes, so that the visibility is more better. So hip is flexed, adducted, tibia is taken for external rotation, the knee is taken towards flexion, go to the barrier and give a thrust. So that's how we can manipulate for the superior tibiofibular joint. So I think these are the important techniques I have just covered about the knee joint, and I will just focus. Lastly, this is my book on clinical symposia in manual therapy, and I'll just show you the last component, one topic about the knee complex. So right. So in this I have written one topic about the knee joint, osteoarthritis, which is very common, and then contributions, and I'll show you the important techniques what I discussed today. One is the knee distraction technique and knee traction technique, and I showed you the medial and the lateral glides and the patellar mobilizations, and I showed you about the taping techniques, the medial glide, medial tilt, and there are 1, 2, 3 steps, and I showed you at the end are the superior tibiofibular joint thrust techniques. So right, so it is in this book there are 16 important conditions, and it is available in, many times people ask where it is available. It is available in Flipkart and Amazon, and my other book is also there, the clinic manual therapy of the pelvic complex. Both are reference books in the Wikipedia manual therapy section, and I think my time is done. So I had allotment of 30 to 35 minutes. So I have finished my presentation, and once again I thank the organizers for giving me this opportunity, and I can see the various wishes from Dr. Sunil Sharma, Dr. Piyush Jain, Dr. Chandrapal Rathore, Dr. Monika Sharma, and from Haryana Chartered Association, Dr. Rachit Singh, Dr. Jitendra Singh, Dr. Anji Abhishek, Dr. Ritu Sahni. Thank you for your wishes, and once again I thank Dr. R.K. Mudgil for his invitation, and thank you Dr. Pooja Digra for your comments. So I finish here. Thank you very much. Thank you.